All right, let's see what's happening here. We have folks joining our webinar now. Thank you everyone for coming online. We will start in a few moments as our audience members register and join the conversation. Good morning, ladies and gentlemen. Thank you for joining us. I can see from our participant list that folks are continuing to join our meeting. As soon as we see a little respite from the folks joining, we'll get started. All right, thank you, everybody. We know folks are continuing to join us. We have about 20 folks online currently, and that number is clicking up as we speak. First, I want to provide a little bit of rules of order or meeting management items for us to discuss before we get started. If you have questions during the session, which is being recorded, as you know, if you have questions during the session, please use the Q&A box and the Q&A function in Zoom on the bottom right of your screen or in a comparable location. It may be different for different computers, but I wanted you to know that we will be taking questions during the course of the presentation and directing those to our panelists. Secondly, we want to have an open and engaged discussion, so please take the time to think about what you'd like to learn from us and ask those questions, because a dialogue is much more interesting for all of us than a monologue. And I can see Jocelyn nodding to that affirmatively. Let me introduce myself. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, or MHDC as we call ourselves. We are, as many of you know, a small but mighty, as Jocelyn has described before, which I found very, very apt, a small but mighty organization with a lot of goodwill and a reasonably good footprint in the health data community. We are especially excited to welcome Jocelyn Keegan and Pooja Babra from PointofCare Partners, who bring to us today a level of expertise in understanding these things called APIs and the effect that APIs can and will have on the health data economy. We live with APIs every day. We see them when we log in to check our flight reservations, when we book a hotel room, when we do many things that require our accessing large sources of information where we don't necessarily want to see everything. We just want to have the access necessary for us to go about doing our business, whether it's flying to a conference, registering at the hotel, getting yourself a rental car if such a thing exists anymore, and proceeding to engage the global economy. APIs are the glue, the modern conduits between individuals and large economies, whether it's consumer products, whether it's travel and leisure, and increasingly healthcare. One of the things we believe strongly at MHDC is not whether APIs will change the health data landscape, but when, how soon, and how specifically. We know that they're inevitable. They save billions of dollars in investments in information technology. They preserve source data and enable source data to be shared in such a fashion as to not degrade the quality of the data. and they are light and reusable and provide the means for granular data access, granular data segmentation in healthcare, possibly granular data consent. There are a lot of scenarios we know. But before we go into that, I would like to talk and have the insight of the experts who have joined us today. Jocelyn is the payer practice lead at PointofCare Partners. Pooja Babra is the PBM services practice lead. And please feel free to live tweet if you are so inclined. Our hashtag is MaHealthData, easy to remember. Ma as in Massachusetts Health Data. And we look forward to your questions and your engagement as we go through today's conversation. So with that, I'll turn it over to Pooja and to Jocelyn. And thank you both for joining us today.
Awesome. Really excited to be here. Denny, and I have a ton of respect for the group and what you guys have been able to accomplish over the last few decades in Mass, and Massachusetts continues to be a leader in so many ways in the industry. Just a little bit more background on me. In addition to being the payer practice lead over PointofCare Partners, we do management consulting. We help folks across the stakeholder wheel from an organizational perspective. I also am the lead for the Da Vinci project and have been actively involved in HL7 and NCPDP and other standards over the years, and spend time in prior authorization. Really is one of my big wheelhouses that I specialize in, as well as payer provider connectivity. I'm going to let Pooja give a little bit more background on herself, and she's going to talk a little bit about POCP and sort of what we hope to cover with you guys today.
Great, thanks, Josh. So Pooja Babra, as Danny mentioned, I'm the PBM services practice lead, and my background has actually been in e-prescribing. I used to send out Palm Pilots to doctors to try to get them to e-prescribe about 26, 27 years ago. So that's how long I've been in kind of the e-prescribing EHR side. And I'm actually on the board at NCPDP and also very involved at HL7, worked on the Care and Alliance Real-Time Benefit Check Implementation Guide, if you're familiar with them, and then also the specialty standard that is now kind of crossing across standards development organizations. So as Jocelyn mentioned, and Joss, if you just want to bump to the next slide, I'm going to run through just briefly kind of who PointofCare Partners is to give you some grounding on that. I mean, you've met Jocelyn and I now, but we've got a whole group of folks that we work with. We always like to say really, really smart folks that we get to work with every day. We're very lucky. So PointofCare Partners is in the health IT strategy consulting space. We really focus on kind of overall company strategy, product strategy, and really business transformation. And that's what we want to talk about today, right? Is Denny did a great introduction on how APIs will be changing healthcare. And, there's lots of rules, lots of regulations that are coming out where you can just kind of check the box. But what we want to talk about is really kind of how to think about this stuff strategically. So we are engaged with different standards development organizations, and in many cases, leadership roles. As Jocelyn mentioned, she's the program manager for Da Vinci. I'm on the NCPDP board. And we also have a regulatory division and a life sciences group as well. So we kind of cross all stakeholders. So, when we talk about interoperability, we talk about APIs, we talk about FHIR, we always like to look at it from all those different lenses. We're all the way from payers, providers, even patient apps, being involved with the Care and Alliance and on that side, as well as our life sciences and manufacturer partners as well, because they're starting to get involved. As we start to talk about how we open up data, there's lots of different use cases. So let's go ahead and just dive in. Joss, do you want to hop down to the next slide? So, what we want to talk about today is really, interoperability. I think there's probably a lot of you on the phone that are really knee deep, right, in unpacking the patient access, information blocking rules that, kind of came out. I just realized like 2 years ago, in March, right after kind of everything shut down. But, not just from a, are you meeting the regulations, but really thinking about kind of, your strategy, right? And how you're going to execute. What's your roadmap around all this? And we have, just some questions that we're going to be kind of tackling and throwing out there, clinical data exchange, price transparency. We're hearing about social determinants of health. How do you capture that information? How do you share that information? And really the bottom line is we're doing this to support value-based care, right? We're doing this to support patient outcomes, and we're doing this to really support, having that patient manage their care, in together with their providers. So let's drop down to the next slide. And what I wanted to just kind of start with is kind of where we're at today, right? The market realities of where we're at. And I know there's a lot on the slide, but I just kind of want to touch on a couple of these. For one thing, just so you guys know from a level setting standpoint, vendors, payers, providers, everyone's kind of figuring out how to be working together, right? They're doing the evaluation. They're trying to understand, how these APIs are going to work. And so if you're in that, in that seat of just saying, we're still figuring this out, you know what? There's a lot of people in your seat, and we work with a lot of clients. I think Jocelyn will always say, right? She with the Da Vinci group, she's got those folks that are a little more kind of forward on the cutting edge, right? That are kind of in the weeds, and they're creating these implementation guides. But we work with a whole group of payers and providers that are kind of like, help me understand this. So, you are where you are, and that's part of the reason we're here, is to kind of talk through some of those use cases. I think the other thing I just want to pull out of this slide is really, the roadmaps today are very heavily driven by regulatory, right? I mean, we've got rules that dropped, and people are reading those rules, and they're saying, how am I going to meet those rules? And again, we look at folks' roadmaps, and that's what's driving it. FHIR has become the way to move, or really the kind of the underpinning, I would say, of the rulemaking. So you'll see that, the FHIR implementation guides, the Da Vinci implementation guides, other implementation guides are actually named in some of the rules. And so, that's what's kind of driving roadmaps today. But again, what we're going to touch on is just kind of how to be thinking about this strategically. I think kind of the third one I just want to touch on before we move on is, the EHRs. I think that, it's important to point out the shift in kind of the role that the EHRs are going to play, and how you can free up data from the EHRs. And I'm going to throw out a life sciences example here, but the fact that we now have access to data that was kind of siloed and locked in EHRs, both from a payer perspective, a patient perspective, a life sciences perspective, even a vendor perspective, it really opens up a lot of opportunities for whichever seat that you're in.
Hey, Pooja, I'm just going to interject for that for 1 second, just to give another example there. So I think that part of what we're also seeing with the shift to EHRs is whether or not folks are continuing to wait for their vendor to supply the API solution for them versus working with partners or even with their provider payer counterparts to sort of work around the EHR and to do the work ahead of waiting for sort of product to show up. And I do think that the move to APIs and the standards are enabling people. So the example that Pooja gave about life science is a great one, right? Now, all of a sudden, you can actually interrupt a workflow and get product, information, training information to a new patient that's gone on some specialty medication, or get information about steps or options from a payer perspective in workflow about where to go and get a service. And that information is now in front of the provider to be able to talk to the patient at the point of care, as opposed to, what happens today, which is you see your doc, they say they need to go figure out how this is going to work. You maybe get handed a pamphlet with a website on it to go and figure out how to enroll in this new product you're in. We now can actually make that happen in real time or near real time, as opposed to what's happened in the past. And Pooja and I have done, dozens of projects where we, have validated over and over again that it can take anywhere from 4 to 3 months to get somebody on a specialty medication. And you don't get on a specialty medication because you're healthy. You get on a specialty medication because something is chronically wrong with you that you're looking for solutions to improve your quality of life, right? So this ability to be able to interrupt from an EHR perspective with either partners or directly with your payer or provider counterparts is game changing to how things have happened in the past.
Yeah, thanks, Joss. And I think, one of the key things is in that real time. I think that's, something we're going to be talking about quite a bit this afternoon.
We may drone on about.
All right, let's go on to the next slide. So this is just more for reference. I think the key takeaway on this slide is we're not done yet, right? I mean, we saw rules drop. People are like, oh, the interoperability rules are out. Well, CMS, ONC, everyone's still working on what's next, right? I mean, prior authorization, I'm just going to call that one out specifically because, we had a rule that came out, got pulled back, but we know there's going to be another rule coming out. And it's funny because I'm on the pharmacy side, right? And we've been doing electronic prior authorization for years now. And so, the pharmacy folks are kind of like, okay, prior authorization, that's already electronic. But when you think about on the medical side, it's still phones and faxes. And so how do we make sure that's becoming electronic? And I think the specialty example that Jocelyn used is a great one because half of specialty meds are covered under the pharmacy benefit, which, you can go ahead and get that prior authorization electronically. Half are under the medical benefit. So, how do you make sure that you are getting that medication in a timely basis? And, you want to make sure that the patient's adherence and actually taking that med, to stay out of the hospital and having to get additional care. Price transparency, that's one I'm going to touch on in a minute, but that's still ongoing. We've seen a couple things come out, but there's going to be more. So really, and then this last point at the bottom right, HIPAA. So just briefly on that, we're all used to thinking about data being covered under HIPAA. Well, now that you have the patient access rule and I as a patient can download my records to my phone and share with anyone, that now puts you under FTC. And I have a great example. I downloaded my daughter's records from just a few weeks ago. She had an accident and I needed to forward it to just a friend who's a doctor. I got in a portal. I was able to actually just share to an email address. And I know I'm able to do that and I know it's covered and I was able to give that consent because, I know to think about that. But think about the hundreds of patients out there, thousands of patients out there that are going to start sharing their data, right? Because they can. That's when we get to that granular level of not only do we need to make sure that people understand the data that they're sharing, say they want to share with a patient app, but how do I make sure that I get that control back? So many things to unpack here, kind of throwing out a lot of examples, but this is the kind of, we're just completely shifting to a new world. And not everything's going to be covered under HIPAA anymore. And that's a really important thing to recognize as well. We work with a lot of provider and payer groups that are concerned about that risk, right? Like, oh, if I share that data, what's going to happen? But, you're going to have to do that. And of course, there's controls being put in place and things like that, but rules are still coming. So just, a lot of just keeping in mind that we're not done yet. This is going to be a marathon.
Just a quick thought and a question, Pooja
Sure.
and Jocelyn. Yeah. As you point out, the regulatory environment is fueling this shift, or is at least providing the motive force to move an industry, an economy as large as healthcare, a $4 trillion economy. But what I read between the lines and what you've mentioned earlier is it's easy to lose the forest for the trees when you're thinking about what regulation do I need to knock down next? What is going to come when I have to do an advanced explanation of benefits? But the reality is, in many respects, and please comment on this, this is a huge strategic shift in the way healthcare will be done. The regulations kind of give you use cases and areas of focus and kind of break the logjam of enterprise data management, keeping patients from being able to use data, to keep patients and their primary care providers from staying in close communication. Could you talk a little bit about, and I know you'll cover this more, but keeping an eye on the strategic forest while you look at these regulatory trees is a pretty important exercise for payers, providers, and others to undertake.
Yeah, Joss, you want to tackle that? I know we're going to get deeper into it.
Yeah,
maybe
so
a preview.
Jenny, I was going to say, can we put a placeholder? So I think there's a couple things that are at play here. And we talk about this all the time, right? In client engagements and in the work that we do in the industry. So I think that we live in a world right now that says, I don't want to be regulated, just let the market forces do what they can to innovate, right? And we all know that that's BS, right? At the end of the day, that so many of the roadmaps that are out there, especially with the large, complex, embedded technology payer provider systems, are driven heavily by regulation. And so we've got ourselves in this situation with, sort of this chicken and egg exercise. And I think what you're saying is, and I think if we think about sort of the freedom we get as people start to think about how do they break down the walls between their organizations, the hard, solid walls between their organizations and the outside world with the use of APIs, and who's deciding to do that strategically versus who's checking the box. And candidly, we get to see people across the spectrum. And there are people that are saying with one voice, we want to be innovative, we want to do different things. But because they wait for the regs, they often end up having to have check the box exercises, right? And that there is no point in time, if we go back to that picture of the timeline, right? That's just through end of next year, regulatory wise. I don't think CMS and ONC can say more loudly to the rest of us, we are moving you to FHIR-based APIs. You need to free data to patients and the people that take care of them, right? Like they have said that as loudly and clearly as they can. So the question is inside of these large complex orgs that we all work in, is somebody looking at this as a strategic play? Are we looking at it as a differentiating play? And I think what's hard is we're seeing, well, what the positive is, we're seeing projects like we've got going on in the FHIR community and multi-stakeholder initiatives like Care Quality that are trying to do the strategic thing or trying to do the right thing and get ahead of the rules and setting the pattern for what the industry should be doing. And that's great. And we should encourage that and we should reward that. But then on the flip side of that, and Pooja's going to talk about patient cost transparency, we have places where when legislation comes in, right, this is something that's coming from the Hill by people that are not tech savvy, that sort of kind of like throws up on all of us, right? Because now we have this complexity of something that says you need to fix the problem, but no, everything we're doing today doesn't have rails. There are no breadcrumbs. And so how do we encourage a place in the industry where we can figure out what the rails should be so that the feds can align us, as opposed to having the feds writing regs for things where there are no standards in place yet, right? And so I think, to me, looking at it strategically and understanding the promise, not necessarily of even FHIR, right? It's really about APIs and the ability for industry to self-determine, I think is where the promise is for all of us here. And each org needs to decide how much I want to invest or be involved in driving that change. But yeah, Pooja's going to tell you why it's hard when it comes from the Hill as opposed to comes out of CMS and ONC's policy shops.
Yeah, so just briefly, I'm going to buzz through my next two slides, but I think this one's important. As Jocelyn mentioned, everything around cost transparency came in legislation as opposed to regulation. And so, Denny, you referred to this good faith estimate, advanced EOB. So what happened is this actually got passed as legislation, but then, you have a deadline of how to meet this, but we have no way to understand how to meet it, right? I mean, it's written in, of course, we had folks that were helping with the language, not us personally, but others in the industry. But again, it's not clear how payers, providers, others are going to meet this. And just as an example, right, it says in the legislation that providers, the referring provider or the main, I can't remember the terminology they use, but essentially the provider that's managing the patient needs to get estimates from all the rest of the providers that the patient may be seeing and provide that to the patient. Well, I mean, you're a provider, you're in the care business. How in the world are you going to gather all these estimates, make sure they're, accurate, and then provide that to your patient, and then of course the payers, right? Like, how are you going to make sure, okay, what is it you're actually going to be providing? You don't know for sure what, the things that may happen. So this has really been interesting because now you've got folks like Da Vinci, and we're going to talk about accelerators and the work in that a little bit later, but you've got folks that are saying, okay, we have deadlines to meet. How are we going to meet that? And so, folks are getting together, they're talking about it. They're saying, okay, let's at least try to tackle what we can do. And you've got then CMS, who's trying to write a regulation around this. So it's all just kind of happening, in different areas. And, we call out on this slide, right? The No Surprises Act is a 3-agency rule. So it's hitting, 3 different agencies. It was a legislative thing. It wasn't a regulatory thing. And we have deadlines to meet. And not only that, you're also trying to cut across multiple standards development organizations. So I think this is a great example of, there's things that are happening that we had to meet, but there's going to be a lot coming down the road where not only do you need to be paying attention, but you need to be thinking about it in a strategic and a roadmap way, right? That longer term, here's what we're doing. And I think just before I turn it over to Jocelyn, I think, I heard on a call once someone saying, when I look at now what's in some of this No Surprises Act and what we're doing, I'm looking at what I already have in place for patient access and payer to payer, and I'm trying to build off of that. And I think that was a really, really important point that we often miss is, we're not always looking to just keep adding APIs and additional work. We're looking at saying, okay, now that I've opened up this set of data, how can I use that to meet what's coming down the road? So when we're thinking strategically and we're thinking about roadmap, we're saying, take a look at what you've already had to build, and let's think about what data you've already opened up. So it's not as much work, right? It's just using it in a different way. So I'm going to I think I've got one more, which is just kind of showing.
But before you move on,
Pooja,
I think given Denny's question, I think there's one thing I sort of want to bring out. And I think the reality is the tri-agency part is a really big deal, right? So, because we have a team at Aubrey High, right, inside of CMS that really understands the power and why we need to be figuring out how to move standards in this work. The other agencies and other parts of CMS aren't living and breathing that on a day-to-day basis, right? Like the folks that are at the head of a lot of this patient access API work and the burden reduction work. So there is mechanics, right, of literally just the knowledge worker business transformation of getting people out of thinking about transactions and getting them to think about in an API way of the world. And then I think there's another layer of complication, which is there's also, I would say that we've done a little bit of therapy in the use cases that Da Vinci has been focused on with the industry to say, there's a law, right? And you need to comply with the law, but there is no regulatory, there's not complete regulatory guidance on how to meet it. And so really sort of keeping the panic out of the industry, right? To say, let's let the regulators establish and let's provide a path to the regulators for what they could do first and second and third. And I think that that's where things have changed really in the last decade with this move to FHIR APIs, is this ability to be able to have a conversation about what could we do today, what could we do tomorrow. We're seeing that with the ONC RFI response around certifying for prior authorization, right? It's a dialogue with the industry to say, what order of operation could we start to ingest and stand up these services? And that is game changing. And I'm a recovering product manager. It is never an or, right? We never say or. It is really about, we're looking with patient cost transparency in particular for the good faith estimate. How do you map FHIR for patient and provider applications to X12, which is what the claim system of payers talk today, and making sure that you can get both data standardized, but also transport standardized in the tool or the technology that's going to be best for different payers and providers that are at a different point in time maturity wise, right? Anyone that basically wants to replace the entire world with FHIR needs to be looked at with suspect, right? Denny, you and I talked about this in the prep session. We very rarely shut off servers, right, in industry. And so I think to Pooja's point, I want to amplify. This is about complementing, adding on, strategically turning, right, incrementally. We're evolving where and how we work together as an industry.
Thanks, Josh. So, this is back to the thing about the APIs. Why is the shift important? I mean, you guys live and breathe this every day, right? We've got these point-to-point connections that are happening in different ways, in different types of documents that are being shared. And I think Denny said something at the very beginning, right? It's more about that granular level data and how you can easily open up and share and make those connections. And so, we're really shifting to this real time, granular, being able to share that type of data as opposed to point, connections that are happening today. And, I think Jocelyn and I were both at Vive a couple of weeks ago, if you attended that. And I remember hearing someone say, and I think Jocelyn makes a really good point, right? We're not trying to transform everything right now. We're saying, use what's working for certain things, but now let's look at some use cases, some areas that we can implement APIs that we can keep things, moving forward, things that aren't working. And I think with that, I'm actually going to turn over to Jocelyn because she's going to get into a little more detail on, some of the specific use cases and just, information that are, the business transformation of how you should be thinking about this.
And while I'm transitioning, I'm going to use a live example of why an API is better than document delivery and collecting data via documents, right? Sort of, I think of it as sort of real time versus archival work. We have a partner in DaVinci that's one of our earlier adopters of the data exchange for quality measures implementation guide. And they've implemented a number of other APIs, but the value prop, the ROI story, that it's multi-care connected, which is the subdivision of multi-care, one of the big health systems out on the West Coast. And they've been working with Regents, which is owned by Cambia, and now a number of other payers. And Regents is working with a number of other provider groups to roll these functionality out. They did a very simple use case, which was basically collecting attestation of 30-day medication reconciliation, which was one of their metrics that they get paid if they do it for the patients in certain populations in at-risk contracts with their partners like Regents. And they used to collect the data 6% of the time as it was keyed into the EHR. And then they would basically have nurses chasing or culling through records to get that data. They made an implementation guide effort. So basically they brought in developers inside their existing EHR. They broke open their Epic themselves, used third-party vendors to do the work. And it took them, I think it was a 6-week project to essentially make the changes to put the DaVinci API in place for quality. Regents did the work on their side in the same time. And they went from collecting that data 6% of the time to collecting it 100% of the time. And that equaled out to, and I'm not going to have the exact numbers, but when Anna tells the story, Anna Taylor, who's the lead over there on this project, she says that they basically will collect, it costs them about $16,000, $17,000 to do the project in bodies. And that they'll collect year one, they collected $17,000 in upside because they increased their collection of that data so much. And now every year for just that one line of business, they will continue to collect that data. And they're now rolling it out for virtually no additional investment because it's a standard API to the second payer, the third payer, the fourth payer. And that same payer that they started with, Regents, is now rolling it out to vendor or to provider site 2, provider site 3, provider site 4. And that's just one measure, right? So it's kind of simple, stupid math when you look at the ROI model from that perspective. And I think that as we look at really across the board, being able to put these just-in-time APIs, that real-time interaction, the data at the right point in time when you need it and no more or no less of the data, those are the types of examples you get to start to tell stories about. And the reason I think this is really important is, to me, the punchline when I get to tell that multi-care story isn't that they save money and they're making more money, right? Of course, when you do a technology investment, you want to make sure that it's paying for itself and that it's going to get dividends. The repeatability, to Denny's earlier points, are incredibly important. But the most important part to me of all of this is the punch, like the mic drop that Anna delivers when she presents this directly, which is they didn't touch the user interface for the providers. So there was virtually no change, literally nothing changed from a provider side. All they did is make sure that when they got the data, they collected it, and that the provider collected the data when it needed to get collected. And it's twofold, right? They didn't impact the provider, and then every phone call they made when they missed data literally was a phone call they needed to make. It wasn't a phone call verifying collecting data that they had already collected and was already in their system. To me, that's what's telling, right? Because when we think about the human bodies that are doing the work and being able to redirect those guys to the call that needs to happen, to the intervention that needs to happen, to the appointment that needs to happen, to the virtual care that needs to happen, like that's how we're going to get the change that we need to see in the ecosystem. Again, we really like pictures at PointofCare Partners. If anybody works with us or sees our work in FAST in DaVinci and the other accelerators, we really like visuals. But I think the main point here is that literally there are so many different places across the spectrum from all of the different seats of where leveraging these APIs and building on that base of the APIs is important. This is the usual suspects. I think that the point we want to get across today is when we talk about investing in APIs, it's really about adding on to what you currently do, getting rid of more brittle or custom and proprietary code that you have between you and your partners today. We're not going to replace everything. We're not going to go and rip and replace things. We're going to evolve, right, from an industry perspective. But I think that the unsaid message here, the thing that's really valuable, is when we look outside of these usual suspects in 3 or 4 people deep into the roles of these organizations, that reusability, that ability to get the data in place or in front of somebody that would be data poor today or would never get approved for the IT investment because they're the secondary or third or fourth user of this information, or they're out in the community, so there's no way they can access it. It's this idea of I think, allowing data to flow where it needs to flow with the right permissions and security, but that getting to places that are completely in a data desert today and that could do so much more valuable work if they had actionable information when they needed it, like your community service providers, like your care coordination teams, getting the information that they need and getting the patient really involved in the middle of all of this, right? Who here doesn't have a healthcare story, whether it's about how much something costs, whether about getting your prior auth, whether it's about getting your meds or your surgery schedule, that's nightmarish. And we live in the data desert right now, right, as patients.
We also live in a desert where 95 or 99% of the healthcare happens, with the individual's self-care, with the family. Many of us have been in the situation, regrettably called the sandwich generation. I think it's multiple generations where we're caring for children as well as parents. We're part of a care team, as are community health workers in Massachusetts. We have ACOs to manage Medicaid, and there's a huge dividend achievable by engaging the patients, the families, and the community service providers who are data poor in doing the 99% of the stuff that happens between doctor's appointments.
Yeah.
So I think this is, what this opens up for patient empowerment is enormous.
And especially when we look at the folks that were left out of meaningful use, right? LTPAC, the SNFs, home health, really these people, to your point,
Right,
that are out in the community servicing our most needy, and being able to get them on even ground and, break down, the silos that we've created around data, that literally has in most cases been created because people want a defensible business model versus actually sharing the data that's needed for a patient at a particular time. So don't let any of my EHR partners on DaVinci hear me make that statement publicly.
we'll keep it between us.
I just really wonder, what were the conversations and those info blocking rules? As CMS and ONC, I always do this. They have this massive lever they have put in place, right, with info blocking and patient access API, and all of us as consumers should be very thankful for their leadership there. So we've referenced, and I'm flipping through the list to see who's here, if there's anybody here that I haven't seen on an accelerator call or in a session someplace talking about accelerators. I think that, to me, and I don't think it's just the accelerators, I think groups like Care Quality, the work that's happening with TEFCA, I think groups that are that are more tightly bound ecosystem partners, like the work that Epic has done with Care Everywhere, or things that we're seeing coming out of small regional areas. Denny, you guys are a great example of this ability to be able to get people together, to be able to talk about the business problem and look at how does the technology enable the business problem. I think that the work that's happening in the accelerators and the success that we're seeing out of creating real standards there is that ability to say, what is the business problem I'm trying to solve and how can I use technology to enable it, versus what we have often done, right? Again, recovering product manager saying, oh, I've got this really cool tech, how can I apply it, right? I think that there's a truth and a pragmatism to the work that's happening in the accelerators, because it's being driven by the subject matter experts inside of the organizations around that stakeholder wheel that Pooja was describing, to actually get at what is the problem and how can I, by making data more liquid or processes more automated, unlock value for the players on either side of that exchange. Denny, I don't know if you want me to talk any more about just the accelerators in general. I can definitely do a plug for fast moving to an accelerator anybody
Well, I
that's
think
on the big
it would
data
be
side of the
helpful.
world needs to get involved.
I think it would be helpful. I mean, there are folks in our audience who probably are not as familiar with these across the board, and a quick overview would be, I think, useful.
I will do a lightning round. So if we think about Argonaut, Argonaut really has been focused from day one. And I would say, as the program manager for DaVinci, we literally said, can we do for payers and providers what Argonaut was able to do about freeing the data out of the EHR? So they were really the first ones, I think, to, I want to say productize, but sort of reveal the promise of getting the data out of the EHR. Where sort of everybody having to check a box and say, I sent a CCBA in the first round of meaningful use didn't quite get us to interoperability. The work that Argonaut did to work with the Smart on Fire folks and with early adopters like Apple to show, hey, if you stand a Fire server up, people can get their information out of the EHR, and at least on a view basis. And then Argonaut has continued to invest in, I would say, foundational technologies. They've picked up bulk, they've picked up really productizing and extending the capabilities in Smart. They've looked at provenance. They're sort of looking at sort of big picture. How do we actually sort of make sure that Fire is going to be ready for purpose as other people start to pick it up and implement it for business challenges? Karen, as Pooja mentioned, is focused on the patient side of the world. So how do we really enable this FTC governed world of patient-directed applications so that me and you individually as patients can get our data to go where we want to go, can get tools to be able to interact with it. And then DaVinci, as I've mentioned, is the payer-provider collaboration, focused really around value-based care, but many of the use cases we're doing are applicable across fee-for-service as well as value-based care. How do we digitize as much as possible the data exchange between payers and providers to get the data at the right point in time so it's actionable? Gravity is focused on two fronts. They're building some implementation guides about how to get data around social determinants of health on a patient level and a population level to flow in the industry. But I think really the core most important work of Gravity is really coming up with a standard terminology and mapping to the existing terminologies that are out there in the industry around how do we talk about and what is the vocabulary that we use to really describe all of the elements and aspects of social determinants. And I think that they will pick up and use and figure out how to get the Gravity data into many of the other implementation guides, and there's technical constructs to how to do that. And then Codex, the folks at MITRE had worked as part of the Moonshot project to really come up with a more expansive use of Fire as a technology in the oncology space. So they developed this profile called MCode, which essentially just created a much bigger universe of cancer-specific terminology for the oncology space. And then they've essentially now started to build guides and workflows to say, how can we get better automation and knowledge sharing between all the different care teams and the reporting agencies and the payers and providers for things like prior authorization with a lens towards oncology. And because that this is often a split between medical and pharmacy benefit and between sites of care, cancer really cuts across so many. It's really allowed them to leverage some of the existing IGs and then develop IGs that are fit for purpose for implementation guides that are fit for purpose for oncology. And they're actually now investigating whether or not they can do the same thing for cardiology. And Pooja, I'm blanking, one other group after that. Genomics.
Genomics, yep.
And so that's actually really exciting to say, can we do the same thing to expand the Fire universe faster to be able to meet those two other specialty areas? Vulcan is focused on how do we really do a better job of bringing the clinical and the research side of pharma and life sciences into the standards arena and into the care process. How do we get more people into clinical trials? Again, you can see really quickly where the SDOH data coming out of Gravity and the work to better automate finding and locating clinical trials could be really important and valuable to make sure that we're getting better representations of us as a population into trials, and making sure that even though you might be sitting in Texas, that you're aware of a fact that a trial is happening someplace up in Boston. In addition, a lot of other ancillary workflows around sort of research, bringing research and getting that real world data back into the research teams as patients are being seen, not just by their oncologists, but by other folks in the care world. FAST started out as a group of, I would say, a party of the willing, that as we were starting DaVinci and Argonaut and Karen and rolling out Fire with sort of those early point-to-point connections, really asking that question of how is this going to scale? How can we learn from our experience in rolling out clearinghouses 30 years ago to make sure that the right, we use a lot of car analogies on that. How do we have the right toll booths, that we have the right roads in place, the right switches in place to deal with large concepts across the fire ecosystem, like identity and security, and a lot of the data modeling, and just ensuring that we're having an industry-wide conversation. It came out really as, I think, a more payer provider heavy conversation as it moves from being a project sponsored by ONC into a full-blown accelerator, the goal to bring more stakeholders from across the industry, the big data guys, getting more different types of care settings, provider settings, not just the big IDNs at the table, I think is really important from a FAST perspective, and the vendors that really understand what it means to scale, just the volume of activity that's happening on a day-to-day in the industry involved in that project. And then Helios is actually the newest announced accelerator, and that's public health. And our friends at CDC, I think, are really grappling with and dealing holistically with what we all learned and experienced and watched with the pandemic, that we've really under-resourced and underfunded, and we need to evolve and mature all of the capabilities for public health reporting and data exchange. And so, that's a vast world with many inputs that are typically not tech savvy, right? We're talking about municipalities and state governments and, counties, and how do we make sure that we can drive the change and shift people to, not switching keyboards from one seat to another to rekey data, but really starting to capture data where it's created and making sure that it can flow in more real time, and so that it's more reusable and accessible by others, as opposed to be sort of stuck in the silos it's stuck in today.
Thank you for that.
I was going to say, that was a lightning round. I'm more than
That was
happy to
great. That was
entertain
speed
any
dating, but it was
questions.
great. I think it was terrific, and I think Helios is this is an exciting evolution of how we go about dealing with technology change in an industry or an economy as massive as ours. As we start establishing the standards for data, the standards for transport, we then begin to see where patients benefit, where payers and providers together can benefit, where public health, as you point out, benefits. These are all really a kind of an exciting evolution of the way we solve problems, in data that is as complex and as challenging as what constitutes health data. And these are public goods. These are, everyone on the call can attend these calls and attend the boiling of the ocean that happens in very small pools, where we're able to look at how to get things done. I think everyone who was on this call, if you haven't had a chance to sit in on a Da Vinci working group or implementation guide meeting, you should. It's a fascinating exercise, and you get to see how people really come together and break apart these complex data concepts and render them into the tools we need and the standards we need to do data right in the 21st century. So thank you for the speed round.
I think it's really important, and I think there's a couple of things I would amplify there. Every one of these projects has a very different governance model and funding model, right? They all are sort of fit for purpose for the part of the industry that they live in, but every one of them has an open access, right?
Right.
The accelerators are building open source guides that anyone can pick up and use for free. Many of them, and some of us might be pushing for more of them, build reference implementations, sample code to, I refer to it as sort of eating our own dog food. We actually make sure the guide works because, again, former product manager, we've all picked up a document and said, what were they thinking, right? When you're actually trying to implement it for the first time. And so this is, there's funding involved, right? There is work to pay people to get focused, to get the work completed. That is true. Right. But the work and the speed at which this work is happening is because it is human powered. There literally are volunteers, like folks from Denny's team, people from your organizations that show up for the calls, that come and test, that disagree or provide discourse on sort of ways to approach things, ways to solve a problem, so that we're not just repeating sort of our previous models, but that we're actually evolving as we move forward. And I think the other point, and it'll be a good pivot to the next part of the conversation, is like the technology is one piece of it, right? When we think about it at the end of the day, and Pooja and I spend our days talking to people about this, right? it's one thing to say, hey, there's this shiny new API you can implement. It's another thing to think about what is the impact to how I work with in my own company and with my business partners, whether they be vendors or payers and providers or other stakeholders that are out in the industry, right? My government partners, my state partners. How does that change? And how do we as an industry really acknowledge that we are going through a transformation that is well beyond simply standing up new technology, right? There's a
Absolutely.
business transformation that's required. So to me, it doesn't really matter if you're a payer or provider or a technology partner. These interoperability projects touch all parts of your organization. And so we like analogies from a PointofCare Partners perspective, sort of whether it's in your basement or all the way up to the boardroom. What we get to see is the people that are doing this well, the ones that are really successful, that are out ahead of everybody else, that are implementing and really bending the curve on how it, in the Da Vinci case, payers and providers are working together, or in the, example of Karen, how we're really getting patient apps out that are going to help solve problems and getting access to the right payer data and provider data that's necessary, is we see that alignment, right? We see interoperability being part of everybody's job, as opposed to some small group of 5 people that know all the things that are sort of stuck onto the side of an organization or stuck in an architecture group. So I think that when talking to this audience today, what I would really challenge people to think about is to think about, how are you guys approaching this from an organizational perspective? Because at the end of the day, you can build or do anything with these APIs. The question is, are you doing the things that are most important, that are fixing your actual day-to-day problems that you're having with your partners? And then how are you starting to unleash data and workflows to enable? And I always use the analogy here about, my husband bought me an iTouch after I left the corporate world. I worked in financial information tech for the first 15 years of my career. And my friends were really worried when I gave up my BlackBerry and then I got a little flip phone and then I lost it and I didn't replace it, that literally something had gone wrong with the world and that I may have dropped out of society. But it was very freeing. So my husband gave me an iTouch, right? So before the iPhone existed, an iTouch. And I thought, well, this is really interesting, but I'm not really sure what these apps are for. And then I proceeded to very quickly get an iPhone. And I thought, it's not a very good phone. I really have to use the headset if I really want to hear the conversation, or I don't want to be screaming at someone, right? Because I'm oppressed as a loud person. And to me, at the end of the day, I still didn't understand why I had these apps, right? Now we fast forward more years than I would care to admit, because I like to buy new technology. My phone is now filled with apps, right, that do very discrete things for me, that occasionally I get annoyed and I have to get out of the app and actually go to the web client, right, and actually look at the full functionality of the site. But that 90% of the things I need to do with my bank, all the examples you gave at the beginning, I can do. And how many calls has that saved? The people, my partners that I work with, my bank, my doctor, right? We're irritated when we can't do something on the app now, right? And that we're not there in healthcare today. So I'm going to give a couple of contrived examples of why APIs are important, just to bring everybody along. And I think that I'd like to tease out, and Denny, have you interject, this concept of, we have data flowing in the form of CCDAs and documents today, and there's nothing wrong with that. We don't need to blow that up. It works. But what could we be doing is we move out of a document paradigm and into APIs, and that ability to get just the data you need when you need it. So if I look at this example, again, highly contrived vignette, right, that I'm walking you guys through, what I'm doing is I'm literally just going to show, if I built these services once, the ability to get payer data, the ability to understand coverage, to understand what the rules are around coverage, to be able to get quality data. This is Da Vinci heavy because that's my world. To identify risks and gaps for that particular patient, to get my prior authorization done, to be able to do referrals and get the data to the next provider, to be able to understand SDOH data about this particular patient so that I can provide them additional services or backstops, or get them into, programs that are going to make sure that they get the care they need. To actually get data from the patient and capture it and put it in the medical record, to be able to get patients to the right clinical trials, right? ... There's a million different APIs I could build, even better if I can base them on a standard. We just literally start at the very beginning of a conversation. I'm having a consult with my primary care. As part of that, they need to figure out what my coverage is, not whether I have health insurance, but for this particular thing that they're going to recommend for me, what is the coverage for me at this point in time. So it's part of a clinical discussion, what my health plan actually pays for, as opposed to this offline back office exercise that happens as I'm walking out of the building. An API would enable me to share other clinical history that I've already given somebody else, or that my payer already knows about me. It helps identify, while I'm sitting in front of you, is there other stuff you should be talking to me about? Are there gaps in care? If you want me to do something, what is it going to cost me? And does site of care matter? Like, is it in my network? Is it out of my network? Being able to have that resonance and that real information. And Pooja and I are here from the future to say, we do this in pharmacy today, and it's real, and it works, and it saves people time and money, and they become more adherent if they know they can afford the drug that's being prescribed to them, right? Like, we know this works. NCPDP has helped figure this out. You know, those are just a couple of examples, right? You know, again, triggering, do I have some sort of risk, you know, some sort of social determinant that's going to make me not be able to get through this journey correctly? So, you know, is there a backstop that needs to be put in place? Is there information about the quality of where you want to send me from a facility or from a particular surgeon perspective? Really thinking about this from a consumer standpoint. Then I get to step 2, we're actually doing the thing, right? So now I need to have permission to do it. If I have to have PT sessions, if I have to get a CT, tell me what the rules are, tell me what I need to do first. All of this can be done by an API. Keeping the patient up to date about where the process is. So if it doesn't happen in real time, actually allowing the patient to have a view in, versus every one of us has done it, called, is my auth done yet? Is it done yet? Is it done yet? Is somebody going to tell me? Why is it stuck? Is there something I can tell you to unstick it, right? We're, as patients, we're on the outside of all that today, right? How do I share the activities that are happening outside of the provider office? You know, in between my surgeries, I'm going to see my, you know, my back guy. I'm going to, you know, get my vaccines done. How does that information get back to that care team that's caring for me, as opposed to what we all tolerate today, which is re-entering the same data 15 times in 15 different places.
And I would say that we know to call and check, right? But there's so many
do,
people that
we
don't,
know.
that just like sit and wait. And it's like, why are you waiting? You know, get on that phone and call them.
We know how to do
we
this.
know how
It's
this
totally
works.
right.
So
Yeah, I use an example of I brought a kid to the ER, local Boston Children's, about 4 years ago, and I knew enough, because I'd been in the doctor's office the day before, that I couldn't get the data because they were in a different EHR than my primary care doc, to get the record sent over, right?
Yeah.
So that when we hit the ER, they would have all of the history. And they faxed it, which was fantastic, in Boston in 2019. And then once we got there, they referred me, and I got an appointment the next day. And I knew, because it was the ER, that maybe that fax wouldn't make it to where it needed to go. So I knew enough to call on my way to the doctor. And this is, I kid you not, the record was now a paper record. The fax had been printed out, and was, because it was a different EHR for the ER than it was for the specialist I was going to see. It was physically locked in a cabinet that was going to be rolled to the place to be faxed and scanned in. And that very nice people that knew that I understood what the problem was and were sympathetic to me stopped the box that had been locked because it had PHI in it, and got it unlocked and got my record out so it could get scanned first.
Yeah.
There you go.
Yay.
That takes SneakerNet to a whole new level of abstraction.
That exposed my child to PHI. And so then when we think about this, right, now what happens if I decide I actually want to pick a different payer, I change jobs, something happens? In the past, that would have been debilitating, right? And I think there's 2 aspects. I always talk to my Da Vinci crew about, well, this is really more of a payer use case than a provider use case. And I've got my little angels that sit on my shoulders that say, no, if payers can get on the provider side, that say, it might be payers talking to payers, but at the end of the day, if the payer is talking to the other payer, it means they don't have to bug us or the patient, then everybody wins, right? So if we think about changing coverage, where does the data flow that the old payer already knows about? Where's the clinical data that payer has collected to be able to do to be able to do care gaps, to be able to understand what programs I'm in, so I can automatically be enrolled in those new programs with the new payer, and that nobody bugs the provider or the patient unless they need to, right? During that transition in care. And I don't have to go and redo everything just because I chose a different payer to pay for my service. So I think that gets to sort of the freedom that we're going to be able to give us as patients in this opportunity. And then I'm going to just quickly go to the last one, which is post-op. how do you make sure that you get all the follow-up, all the support if there's SDOH, considerations around mobility, transport, access, right? That you can make sure coming out of whatever service happened, how do you measure it? How do you make sure you capture all the information, get credit for all the good work you did around quality? And so everybody gets paid, right? The reward, the upside for that. And then how do we make sure that the patient can then take that data with them wherever they need to take it? And how do we make sure that you get to catch the interrupt, the patient survey to say, what could we have done better to go back into those workflows to figure out what APIs are missing?
I think one of the things that we talked about in our pre-meeting yesterday is how different this is from TEFCA, for example, which is in many respects really designed to be the document exchange standard for providers, largely hospital providers, larger medical groups. But document exchange, the use of CCDs and the like, are really have their origins in putting in front of a physician additional information that physician may or may not have, some of which will be redundant. It might overwrite what the physician has with older information, we don't know. It may also provide more information than is needed for a particular question or a particular type of encounter. The thing that's powerful about APIs is they're driven by the business need or the clinical need first, and then you define the data and the transmission standards you need, and you get answers to the particular questions you have. You can reuse these APIs for a lot of things, but they're very focused on getting answers to problems and questions rather than here's a whole bunch of information. Maybe you can make a better determination about patient care or what have you, but APIs really are designed to answer questions as opposed to providing more information, which I think is an important distinction to make between sharing information and providing answers to questions.
I think I think it's such a pitch perfect point. To me, I think that, there's a lot of value in being able to move data around. And I think that we started with a document construct because that was the world that we lived in. And I think now we're talking about what that next evolution is. So I would push on the TEFCA piece to say, I think that it's on all of us, and Posnack might duck and cover when I come his way, to make sure that whatever we're doing with TEFCA becomes FHIR enabled, and that we can get down to this data point level of being able to, how do we build on the rails that we're building for TEFCA and make sure that we don't lose the progress we're making in APIs along the way. And we're smart people, and I think that we can figure out where that makes sense and where that doesn't make sense, and where things need to be point to point and where things need to be routed through networks. To me, I think that there's a couple things that I think that I would say as we sort of think about, like, how do we think about this in terms, and sort of Pooja and I could probably like set on top of a mountaintop and just scream this till we're blue in the face every day. I think that at the core, understanding that these are not technology projects. This is not about rolling out your latest API or your coolest whiz-bang vendor that's going to fix all your problems, right? There are no silver bullets. This is just about making sure that you've got all the people from across your organization involved, because they have to be thinking about what is going to be the impact of moving to these APIs. How are their business processes going to change as data gets shared in more real time? But also, what could you enable and what could you do faster and better if these different groups, it's not just about clinical data. We're starting with clinical data because that's where our biggest pain is, but that we're seeing that getting the right clinical data at the right time to any one of these functions and making sure that each of the groups is informed. We hear on a regular basis from providers and payer teams that are trying to get this work done. There's regulatory action out in the market to implement these APIs and use them. And they're literally dead ending inside their own legal departments that are so conservative and controlled about what they have to do. And I don't want to say using HIPAA as a veil, but because HIPAA shut down sort of data sharing in so many ways. So I think it's about sort of what is that evolution that your org needs to take to think about living in a world where data is fluid and accessible, and how are you securing it at the right place and the right relationships at the right layer with the right provenance and the right ability to control on and off. I think it's a whole product approach, as opposed to just, there's some guys that stood up an API on the side of the business and that checks a box for compliance, versus actually entering the current century, right? And how we think about what is the fabric that you've got inside your organization to get the right information where you need it, when you need it.
And I think we've heard over and over again, right? There's people that are focused on interoperability, and we like to say you've got to have the whole organization, because people just don't understand. And you know, we said at the very beginning, right? It's a whole shift, and if you don't have your entire organization on board, right, you're going to have an interoperability department. And I think that was the point of the last slide, right? It's not just an interoperability department. I mean, it's going to touch everyone across the organization, and trying to get people to understand that, you know, is often hard for folks. You know, we live and breathe it every day, and it's easy for us to say, oh, this is all coming, but you know, there's champions in the organization that have a hard time getting that message across. And that's a really, really important thing, is it's really a big shift for the whole organization. And it, you know, you can't think of it as just a department.
And I'm not going to belabor this slide other than say, you know, we just came out of spending a week at Vive and a week at HIMSS, which I'm just going to tell you, it was amazing to see other human beings face to face and be able to hug them and see the progress they've made over the last 2 years.
We exist. We're not just, we're not
That's
just, you know, video representations of ourselves.
Three dimensions. Actually,
we live in 3D,
how
right?
Tall and short people are that you've never met before in person. I mean, it was comical. There's a lot of probably not safe, but probably totally fine hugging going on. But amongst people who had never met face to face, but have been, you know, three-dimensional or three square boxes with each other on a screen for the last couple of years. But I think that the main point here is to say, you know, if we look at, you know, each of your organizations today have complex relationships, complex partnerships. You're using multiple tools. I always like to use the example of one of the large regional payers we worked with on a project, who we were trying to get across the point, the provider burden they were creating. And we did sort of a cross-functional look at their overall interoperability plan. And one of our takeaways that I think really resonated with the leadership team was just them around 2 or 3 different areas of the business between risk and quality and care management across their different lines of business were hitting the same, because they had picked different point solutions for vendors, for partners, for, you know, existing portal tools that were out in the market. Just their one line of business, this one payer, was hitting an individual local provider organization 17 different ways with different tools for different data sets that were often the exact same data for that patient, right? So if you think about that and you multiply it by 20 to 50 payers that somebody has a relationship with, and you think about providers that really want to take the leap to move into at-risk contracting more aggressively, like that is just insane, right? So the question is of all these activities that are happening out here in the market, you have to decide who your core partners are. You have to decide that you're not going to just work with your core partners, because all of us work for large complex organizations, and you have your core partners, and then you have the long tail of either other payers you work with, other providers you work with, other, you know, partners out in the industry that are core to your business. And then how are you going to decide what order you're going to do this work, right? It's not, I said it at the beginning, it's never or. I mean, I'm sorry. Yes, it's never or.
It's never or, right?
It's never or. It literally is, what are we going to do in what order? And it's an and, right? I think the ordering is the thing that we see people really struggling with and being overwhelmed with. So we've been doing sort of this checklist conversation and a bunch of early conversations and projects that we do today, which is, you know, think about sort of your work and your workaround strategy more as a checklist. And do you have the right ROI models in place and prioritization tools in place to be able to help yourself with the different partners you're working with figure out what your order of operation is. And so we'll leave you guys for that to shift over to just more of a general Q&A. But if you think about each of these areas, whether it be strategy or whether it be prioritization, you know, having frameworks and ways to make decisions in a methodical way in these large complex organizations is key. And candidly, you know, we see on a day-to-day basis, whether it's a payer or provider or vendor organizations, you know, that people are still making decisions case by case inside of an individual business silo inside of those organizations. So,
right.
So it's time for people to pick their head up and get the heads picked up in the layers above you in your organization to be able to look at these solutions more holistically and really be able to lean into the reusability and the promise, right, that you can get as we shift into APIs. because the feds are making us do it one way or the other. So,
Well, one point you raised though is reusability. This is
Mhm.
that's a very powerful concept about APIs. We tend to think of, we have the API for price transparency, we have the API for payer to payer, we have the API for patient to provider, we have the API from patient to payer, and many of these are
the same
with
API.
simple adjustments the same
Yeah.
API, and
Yeah.
that as organizations start using APIs, they're going to find that rather than having to build something completely different for another use case, what they're building is reusable and has, the opportunity for them to achieve ROIs even greater than the one you described originally, Jocelyn, which is
Right.
we get to use this not only for the one that gave us a full, return on our investment in 1 year, but now we get returns on our investment from other multiple applications of the same API. And that reusability and that kind of replicability for APIs in different business and clinical contexts is a really important piece of that. Can you talk a little bit about, Pooja, you or Jocelyn, you, a little bit about reusability and why that is something that organizations should really look at when they think about APIs?
I'm going to
Yeah.
give, oh, go ahead, Pooja.
Oh, I was going to say, I mean, I can throw that that cost transparency one out, because there was a payer on like a webinar like this that basically said that, when they're looking at having to now do this EOB, they're looking at both the patient access and the payer-to-payer APIs to say, what data have I had to already open up that I can now use and make this, be able to create this. And that's where I think it's really powerful, right? Because you're already opening up, the patient data, the claims information, all of that, as well as now having to share information, say if the member moves to a different payer, right? The payers are having to share that information. So they actually did an exercise where they had the business people and the technical folks in the room that said, okay, based on these two APIs, what's the information we're currently sharing? Who are we sharing with it? And can we now, take that information and create something to do this, EOB that we need to create? And, that's an exercise that people should be thinking about as they go through that. So that's just, just one example. Joss, go ahead.
And I think that, I think that there's one thing I think that I would probably highlight that I think is sort of a little bit of a rage against the machine aspect, right? So we get to work with some of the largest payers in the country, right? And we get to hear things like, I can't even get a project approved unless it's going to prove it's going to save $100 million from an ROI perspective, right? If you're thinking about deploying small projects and incremental change like these APIs, that model, that decision-making model is no longer valid and is limiting your innovation, right? So I think people need to look at that. But to add on to Pooja's point, I think the people that have chosen to master their own data, and I think this gets back at my commentary I was making earlier about the EHRs, right? As these large IDNs and even smaller players, right, as they make their technology investments in their next EHR or their current EHR they're going to continue to invest in, who's mastering their data? And it's not just mastering your clinical data with patient cost transparency, it's now also mastering your contract information, which is not standardized in any way at all, right?
No,
So
it's
how
not.
do we, as players, right, on either side of one of these transactions, master the data, have control of your own information so that you can leverage and use stuff that other people are offering you via API? If you choose to do it from a data mastery and from a data lake perspective so that you're owning it and you're controlling it and you can interject and get additional data into your end user UIs when you need to, then you're in a lot more control than someone that is waiting for a productized solution to come out that's going to do this for me. Now, that's not to say that you couldn't partner with somebody that has productized these APIs, but that there needs to be a step with who are the partners that are going to be able to serve up APIs across these business domains, right? I need somebody that doesn't just do patient access API. I need somebody that's thinking about the entire suite of things I'm going to need to surface from API, because once the data is loaded and normalized, then the lift to do project 2, 3, 4, 5 just plummets, right? From a cost
Right.
and a human, I mean, just the people inside our orgs that know the clinical data, that know the claims data. Often it's the people that are the rate limiting step. It's not the money on the project. It's, do we have the staff to be able to do it? So if you think about really this data mastery and this ability to be able to have flexible tools that are going to allow you to reuse these APIs and to adjust them and manage them, that really the question becomes, your rate limiting factor is, how can you figure out which of these projects are most important and are going to impact your business the most first, or that you need to learn the most first about to then order them. It's not a matter of, I'm going to have to wait 3 years out to get approval to start a project that's going to cost us $20 million, because I now can do these short iterative projects to actually solve real business problems inside of the current year or in the next year, and that the ROI, because the cost of the project is so much lower, becomes much more manageable and sustainable, because you can actually see the impact of that benefit day one. And again, I'll be totally blunt. We're on step 2, 3 of a staircase of 2000 here, right? But are you doing one-offs now and eventually you're going to switch? Or should you be building your foundational tools now? And I see it as a competitive advantage for the people that are trying to figure out how to do it now versus waiting to see whether it's real, whether it's actually going to get used. Because the rest of the world, this is how it works, right? Healthcare is unique in the fact that we have not moved to APIs on force yet.
We have a raised hand from Eric Hillman in our audience. Eric, I'm going to allow you to talk and tell us what you want to share with us. You're on. Your microphone is turned off. Let's see if we can ask you to unmute. Well, while Eric is unmuting, Eric, I can see you. You need to remove your mute, turn your microphone on.
There we go.
There we are.
Hey, sorry about that. That was an error. I was clicking the wrong thing.
It's never happened to any of us before. We're shocked to discover that you've had that happen to you, but go ahead and ask your question.
No, I didn't really have one. That was an error.
Oh, okay. Well,
we're going to calling on participants to talk now.
Well, that's fine. Thank you for inadvertently raising your hand. And we appreciate your honesty with us, which is something all of us have found ourselves in that position of either raising our hands or pushing a button that we didn't expect to push. Let's go to a second question that I have, which is, you talked to Jocelyn about, these things get tied up in organizational ROI discussions, which tend to fall away from the fact that we have established incumbents in this industry who are suffering from patient or member estrangement. Yeah, and I mean that we are not doing a good job today at engaging patients, at meeting members where they are, at understanding what is critical for health plans and for providers to succeed going forward. The episode of my wife needed to see a new dermatologist when hers retired. She got a referral from her primary care doc, and the appointment was available in 5 months. My response to that is, let's find another dermatologist. Let's look at anyone who's in network, which would be provided by me through any one of these APIs if when the time comes and I can access that on my device. But can you talk a little bit about how APIs and the use of APIs will bring patients closer, will bring members closer to the organizations that are responsible for their clinical care and the management of the cost of their clinical care? Can you talk a little bit about that?
I think this is really great, because I think that I'm laughing as you're talking, because I'm thinking what your wife is saying in her head is, you're saying, just go find a new dermatologist. What she's thinking is, but this guy is good or woman is good because they have a 5-month wait. So they must be good. So I don't want to just go randomly pick somebody off a list, right? Because if they have availability, are they really a good dermatologist?
Right.
That is the mindset that we bring to care today. I'm being a little tongue in cheek there, but I do think that, this ability for us to not just be able to figure out who's in network, but the quality from a consumer perspective of who's used that provider, and being able to understand the quality of that network, being able to understand your costs to use that particular provider, because there are people that will make cost-based decisions, and there's other people that are very fortunate that don't need to make cost-based decisions about their share is. I think another part of that that's really important is, as all of us go into more and more complex products from a payer health plan coverage perspective, and we take on risk, I think there's two divides, right? There's the people that are buying a plan on an exchange because they have to, and they're sort of doing a leap of faith of how much cash they're going to need on hand to pay their benefits. Then there's sort of everybody in the middle that's sticking on their regular fee-for-service plans, are happy, fat, commercial plans. And then there's folks that are like, hey, maybe there's some upside and I can take some risk because I can afford to pay something because I'll have this HSA and it's getting partly funded. The people that are on either extreme of this literally are taking leaps of faith, right? None of us, and again, to Pooja's point, we know how this works. I've been in 4 at-risk contracts over the years, right? For different employers. And every time I sign up for one, I know how much money I think I need to have in the bank, of what's my max out of pocket every year. And then I roll the dice about what's covered and what's not covered, right? I can do that because I live a nice affluent life in the Boston area. And most of my providers are in network for the payer that I happen to be using, right? But you think about sort of the what other place in our lives could you afford to increase that much risk? None of us would buy a car that way. We wouldn't buy a house that way, right? And at the end, we probably wouldn't even buy a meal that way, right? At the end of the day, but we tolerate it. So I think that as more and more of us take on more and more risk in our actual contracts because costs have continued to escalate, and as more and more folks move to supplemental plans, right, as the population continues to age into Medicare Advantage, I think that we're going to see plans that are looking to differentiate themselves by giving those better tools. And we're seeing it in the Boston area, right? I mean, I happen to go to one of the large, multi-hospital systems here in the Boston area. And, they are losing patients because patients can't get in to see people. And there are smaller regional systems and independent practices that are inheriting those patients. So there is a consumer aspect, whether people can articulate and understand it from a business perspective, that's why, that it's the service level that they're providing that's actually providing that window of what's changing and how they're being affected by what's happening in the industry, and whether they're intellectually honest about that or not, I think remains to be seen, and we'll probably only know about it backwards, right, from a case study perspective.
Right. Another thought that is important in our world, as you guys know, MHDC is undertaking, this will be a shameless plug, but we're not selling anything. We're undertaking a real-time Da Vinci implementation guide-based prior authorization prototype and a market assessment and a policy strategy with our partners, the Network for Healthcare Innovation, for Excellence in Healthcare Innovation, NEHI. And part of what we're really focusing on is how do we create an experience for the patient first, the caregiver second, that is as burden-free, or relatively speaking, unencumbered as it is compared today. Could you talk a little bit about, our belief is that if we can, kind of like New York, if you can do it here, you can do it anywhere. If we can do something as complex transactionally and as demanding on organizations participating to have their digital houses in order, if we could do something as complex as prior auth using your implementation guides and using the data standards that are embedded therein and the APIs that FHIR provides the framework for, can you talk a little bit about how that works? You see that in your world, and how something like that lays the groundwork for organizations to be able to do more. If we ask people to do prior auth this way, they can do a lot more. What is involved in prior auth is like a compound equation. If you can break it into the smaller pieces, you can do smaller, more discrete things much more easily, like finding out whether a patient has the benefits to cover an anticipated service. Everything doesn't have to be on demand, real time. It can be in advance in some cases. Can you talk a little bit about the future as you see that?
And I'm going to talk about the future, and then I'm going to pivot to Pooja so she can talk about the reality of how that is happening on pharmacy with real-time benefit check being put into production over the last couple of years, both in a proprietary and an emergingly standards way on the pharmacy side of the business. So I think the first thing that we grapple with is, And I think this is it's part philosophy and part reality, which is we have designed products from a healthcare perspective that are more complex than the existing tools we have to manage them can manage, right? So I think the first step when we think about prior authorization and sort of that equity, I refer to a lot of the work that we're doing in Da Vinci around really creating transparency and information equity between the patient, the provider, and the payer. The provider should know as much as the payer does about that patient's benefits. That's the first step. And so if we think about the first implementation guide from a Da Vinci perspective, it really is that ability to be able to say, what are there for coverage requirements? What type of coverage does this patient have? And is there anything that needs to be done before the patient has this procedure? Literally just answering that question in workflow, or to your point, if we know what the appointment is that somebody's coming in to see, that an MA or a team member can pre-check that before the patient shows up is amazing, right? That's game changing. Right now that happens as a completely separate workflow. If I had the ability to check that on a patient perspective, and we can unpack this probably in a future conversation, when we talk about apples to apples comparisons about what I can look at as a consumer versus what my provider can create for me for an estimate or for prior authorization, it's generally hard to do that one-to-one mapping because there's so much variability in sort of how you ask permission for something at sort of the ICD-10 code level and what the package of services are. And so we see a desire and a movement in the industry to normalize those requests from a payer or provider perspective. But I'm here to say that's not a hill I want to die on. I want to figure out how to get automation in the existing tools. And if that allows us to move to our more generalized standards around how we package things, I think that that's going to be an important side benefit of the work that we're doing around automation to show that there really isn't as much variability as people like to do. But I don't want to stop our progress by saying that that has to be a predecessor. And historically, the first version of standards for prior authorization on the NCPDP front, the pharmacy side, actually failed because people wanted to standardize everything, not just the way that you ask the questions. So I think this coverage requirements discovery is the Da Vinci implementation guide. This ability to say, is it covered or isn't covered, is incredibly important. And it seems simple, but it's game changing. And then having the provider, similar to what you can see in a real-time benefit check, understand what the requirements are for coverage. Is this thing I'm asking for going to be covered? What is the data that I would need to supply? What is the proof or the clinical evidence that I would need to supply in order to be covered for this particular request at this particular time with this particular provider at this particular location? That's really important because any of those variables change, whether the doc at the end of the day gets paid or the patient gets hit with some big unexpected fee, needs to be able to create that package, right? So enabling the patient to be able to monitor that offline versus the patient to be able to create that sort of day one in the early days, I think is going to be more important. And how do we get the patient involved? How do we allow them to have a view into the progress? If and when a payer or provider are working closely enough and they have high enough trust, the ability for that data exchange and that request to happen in a more automated way. Does the data reside in the EHR? Is the proof there? Well, then you don't need to do a prior authorization because I can see the med necessity is there in the patient record so that I can auto approve this. That's the promise, right? But many prior authorizations are really complex. So if we think about our goal with the work that we're doing here, it's not removing the need for prior authorization. It plays a role in the industry. As providers go into more and more at-risk contracts, they're actually asking their payer partners to help them do utilization management for their at-risk contracts, right? There's a reason prior auth exists, but being able to get rid of the ones that say, well, do this instead of this, and there's no prior auth, it's, medically the same treatment, you're just picking a different formula, something from, the formulary list for specialty meds, or you're going to a different location, or, oh, you just need to find out you need to do the PT now. That's to me about getting rid of, I call them soft denials, things that are just going to get people to remove friction because they have better idea at patient-specific coverage. And then when and if you need to do a prior auth, how can you automate as many of them as possible where you need proof, right? You need the test score, you need the imaging done, you need the predecessor task done, and the proof is in the EHR. How do you automate it? So it's seamless. We do EMBs, millions and millions of EMBs every day to check whether people have coverage. Nobody thinks twice about them. If we can make a prior authorization like that, so we're just exceptional handling the complex cases where there's a legitimate need for this patient doesn't meet necessity, and the doc feels like this is the therapy they need, and we need to open that conversation between a provider, payer, team and the provider about why they think that this is the right treatment, then that's where we spend our energy and our time and our people, right? Doing that, but still automating as much as possible. Now,
well, automation brings automation of the transaction brings transparency into the policies, and into ultimately, you know, the guidelines, the clinical guidelines that providers use, the payers use. And as you point out, providers are in the same boat. As they take on risk, they need to use the same kind of tools to manage exposure to financial downside. And the idea that we can first get really good at transactional transparency, and that opens up, why are we doing this the same way? We've done 10,000 of them this month. Maybe we can do something different, has always been one of our guiding principles. But Pooja, I didn't want to interrupt your contribution to this discussion.
No, just real quick. And I think what Jocelyn was alluding to was, you know, on the pharmacy side, we had the real-time benefit check, which, you know, rolled out maybe 7 years ago, I think. And essentially what that is doing is, you know, as a doctor prescribes a prescription, they're able to, in real time, hit the PBM, find out how much it's going to cost the patient out of pocket, if there's alternatives. You know, it also brings back the prior authorization flag. So for many years on the pharmacy side, we had a static formulary and benefit file, which would give some of that information, right? It would at least say whether it's on or off formulary. Then we moved into the real-time benefit check, which is the real-time, yes, this is covered and this is how much you're going to pay at the pharmacy, right? So the doctor can have that information to give to the patient. Well, the Caring Alliance actually took that one step further. And what we decided to do, you know, Caring Alliance kind of reached out to PointofCare Partners, knowing that we were very involved on the NCPDP side. And they said, you know, we want to bring this same transaction to the consumer, because we know providers are busy, right? I mean, they're not going to be able to have that conversation and say, oh, patient, this is how much it's going to cost. Maybe if you go to this pharmacy, it's going to cost you a little bit less. But, you know, we as consumers on, you know, I the other day I was on Kayak, right? And I said, here's where I want to go. You know, it gave me the prices of like 6 different airlines, and I was able to comparison shop. Well, we as consumers should be able to do that on our healthcare, right? And starting with prescriptions. I know for a fact that I usually go to the CVS down the street, but you know, if I go to the Walmart or the local pharmacy, it may cost me less. You know, it's still covered under my insurance, but my doctor's so used to, I told my doctor, right, send my electronic prescription to the CVS, and you know, I'm paying that price no matter what. Whereas we have a choice, right? We can go to the Walmart, we can go to the local pharmacy and maybe get it cheaper. So what we did on the Caring Alliance is we said, we're going to take that exact same information that the provider is getting through their EHR, and we're going to provide that to the patient through an app. And so we built, you know, the APIs, we built an implementation guide that says, we know that as a patient, I'm not going to need all the information that's coming back from that transaction to the provider. But if I can understand what it's going to cost me out of pocket, if I can understand, you know, these 5 different pharmacies do a price check, and if I can find out that, hey, by the way, there's, you know, a coupon or there's a discount program that I can apply, you know, I as a consumer can make those choices and say, you know, I'm going to get my prescription filled from this other pharmacy. I'm going to use this coupon, and I'm actually going to be able to fill it because it, you know, it's costing me less. And so, you know, as we think about, you know, what are we putting in place, even from a prior authorization standpoint, right? Wouldn't it be great if I know that I'm waiting for a prior authorization, instead of having to get on the phone, right? Be able to go and check my app and say, here's where the prior authorization is in the process. And what's interesting is on the pharmacy side, we're starting to do more and more of that. And I think that's something that, you know, as we start rolling these out on the medical benefit side as well, we're going to have to start doing that. Now, again, you know, we have these on the pharmacy side. I'm not going to say that they're completely 100% transparent. You know, we're still working with the PBMs to implement things. We still want to be able to bring in the folks like GoodRx, right? And say, okay, here's my benefit. Here's how much it'll cost me if I use GoodRx. And I want that in one place. So, you know, still work to do, but at least we're starting to get that data to open up. We're starting to get that same information that the physician is seeing, you know, in the patient's hands. And so it's just one step as we kind of keep going down this path, or up these steps of opening up the data and making it more transparent. So
Rita Auerbach, I'm going to allow you to talk and ask your question unless you have inadvertently raised your hand. Your microphone, let me make sure you're unmuted. And Rita, what's your question? You're still on mute.
It was inadvertent.
There we, oh, it was an inadvertent question. Very good. Okay, let's just go. I have more that I want to ask, and I'm mindful of our time. So let's just, we have a hand raising. We've created a hand raising phenomenon among our audience. We appreciate it, however unintended it is. When we talk about, the change in the health data economy that APIs can produce, and the increasing amount of, the increasing empowerment that patients will experience as they get access to their health data, we start to begin to think about how the economics will shift in this industry, how, patients will increasingly drive new models of care, new models of coverage based on their unique needs and their unique clinical as well as financial requirements. Can you talk a little bit about how does this kind of interoperability help those among us who are on the margins, those who have, we often hear the argument, not everybody has a smartphone, or not everybody is part of a health system that is necessarily going to make this information available to them, and or don't have access to these services in many parts of the country where they may not have access to health insurance coverage at all. Can you talk a little bit about the promise of APIs as it relates to the disadvantaged, those for whom health data and the power of health data are largely denied?
So I'll talk a little bit about the technology aspect, and then I'm going to push it to Pooja to talk a little bit about sort of the impact of getting more able to sort of codify the information so we can better identify people that are at risk, right, in the working gravity. But I think that if we think about it from a technology perspective, I think what's really important is to understand that the more you standardize things and the more they're available via API in a bite-sized level, the more you level people's entrance to be able to play, right? And I think that, today, like in many industries, I spent the first half of my career in financial services, consumers through regulation were given equal access to information than traders, right? And that was something that happened in all of our lifetimes, right? We've spent the 100 years previous to that to people getting advanced information to trade in the market, right?
Right.
I think that I would view the transformation here very similarly. If the data is available via API and the lift is an application, the ability to innovate and to be able to get to those endpoints becomes so much more doable. You don't need an IT staff. You don't need a dedicated CapEx budget, right? People will provide the services. The availability to get to people where they are in reality, whether you're communicating them to them via text, via phone, via a secure email, our ability to be able to understand our networks of people, I think, increases. But again, this comes back to the investment in mastering the data and the information. I listened to a Vive roundtable that I participated in. I listened to one of my very dear Da Vinci colleagues who works for one of the large health systems out in California, maybe potentially heckle our dear Mickey Tripathi during a roundtable where basically, the ONC CMS perspective is everybody should be delivering ADTs electronically. And, the person from the provider group was very able to say, hey, I look at my provider directory data that I get, and I can't, in the directory data that I get in my state, I don't have a digital direct address. I don't have an endpoint for them. So I have to fax the ADT to them because that's the state of the art, right? So I think it comes back to this, how do we master the data and require the data to be clean? If we're putting the data in 1,500 different places and everybody has to update the data individually in 1,500 places, the data is never going to be clean, right? If we can provide data as a service, whether it's directory, whether it's benefit information, whether it's clinical information, our ability to master that data and have it be correct and accurate at the point of service when you need to use it is going to increase immensely, right? So I'll find out, oh, this person's preference is to get messages via direct, via email. Oh, they want a text message with a link, a secure link back to a portal to be able to get to it. Oh no, this person I have to mail to. And then we do mail to them because that's we're meeting them where they are at a given point in time. I also will make one other comment. I think one of the silver linings coming out of COVID is the investment in rolling out technology to the more rural parts of the country. And I'll use a live example. We own a cabin in New Hampshire that literally had DSL up until last year through investments with COVID relief packages. That valley in New Hampshire, which is kind of in the middle of New Hampshire on a tiny little mountain, now has high-speed internet for cheaper than what I pay for my high-speed internet on the South Shore of Boston, right? And so those sorts of changes, I think, are going to help us get people across that digital divide and be able to meet people where they are in reality.
Yeah, and I would just add to that. I mean, I think we're just starting to unpack all this, right? I mean, we did some work around e-consent and, you know, around health equity and e-consent. And, you know, it's fascinating to listen to folks in the social services area because, you know, when you think about care, it's not just providers and payers, right? Now you've got so many other social services. And what we're hearing is, you know, they don't have IT people. They're not going to be able to stand up fire servers, but they're making things work. And I think to Jocelyn's point, right, text messages, or, you know, if we know that we need to do things on paper still, but the fact that they can somehow access the data in a way that they can get that, you know, people are making things work. And I think there's a lot that we're just going to start learning about. I mean, ONC, right? Every single conversation we have, we hear them in is around health equity, even CMS. And so I think right now we're just at the beginning of kind of understanding, you know, how this is going to impact. And I think, you know, we alluded to earlier, we had on the slide Helios, right? I think that's going to be kind of our first, you know, kind of foray into how are we going to do all this technology stuff with public health, with social services, you know, with folks that may not be connected electronically. And so it'll be kind of interesting to see how things play out. And if you do, you know, you can go out onto the HL7 Confluence site, you know, they're looking at use cases today. And so it's really interesting to kind of see the use cases they're looking at, because it is, you know, not just our normal payer provider life sciences, it's, you know, food banks, it's, you know, public health
right, community service workers,
community service workers. Like how are we going to do that? So I think, you know, it's a long road, but to Jocelyn's point, I think, you know, luckily, or, you know, I mean, because of the pandemic, right, there's funding there. And so now it's a matter of how do we make sure that we get kind of those fringe folks and the folks that are normally not connected electronically connected in order to be able to share some of this information and you know, use these services. So
well, thank you both. Before we wrap up, I want to ask if you have any final parting comments or thoughts to leave our audience with today.
I mean, I think from my perspective, I can't emphasize enough how human powered this work is. And that doesn't mean that you have to do it full time. You know, to Pooja's point, you could pick one use case that you spend an hour or two, you know, a few times a month on, and your voice, if it's the thing that you know the most about, and sort of having that truth about what happens today in the real world, you know, to mash it up against how would you fix it, you know, using a technology like Fire or, you know, wherever you choose to participate, I think is incredibly important. And then the second point I would just make is that, you know, you have to think sort of organizationally in a more systemic way about what's your strategic goal here, and get out of the mindset of, you know, we don't want to be regulated, but we'll wait to see what's in the regs to figure out how we populate our roadmap. I think being able to divorce your organization from those sort of behaviors, I think becomes incredibly important, but we appreciate that that's much easier said than done. And so what are the tools and the ways that you need to look at that domain to be able to have those hard conversations inside your organizations, but that you need to start them now, right? Because things, we're on a path and we're headed down it. And so how does your org make sure that you're aligned to it?
Yeah, and I would just kind of close out with what Jocelyn just said, right? We're on a path. We're taking the first few steps. There's going to be a lot coming. So, you know, keep that in mind as you're looking at that. And I think just emphasizing that point of these aren't meant to be, like we said, kind of individual APIs, right? Look across. I mean, I think that's going to save so much time and energy, is, be thinking about how you build on what you've already done with APIs, and don't look at them as kind of individual, projects and things you have to do. Just reuse, things like that you would be able to build on is really important takeaway, I think, for the group here. So.
Well, I want to thank you both, Pooja, Josh. This has been fascinating and extremely informative. We are active supporters of the work that you do. We, as you know, we are probably one of the most active representatives or constituents when it comes to participating in your work. But we want the Massachusetts health data community to know what's happening, and to take advantage of the fact that because we have almost everyone in the Commonwealth ensured, that we can advance health equity, we can advance improvement of quality of care, we can reduce cost, improve value, and that getting there is via the API and via the underlying work that individuals, as you point out, the human power brings to taking things that were sort of difficult to reach, too large for the average person, the average consumer, the edifice of health information technology, and suddenly disintegrating that and putting it in people's hands, and creating organizations that are able to engage with patients and members in a very intimate way, by means of these simple but very scrupulously demanding APIs, as far as data quality, as far as how they're put to use. But we are on that path, and we wouldn't be on that path if it weren't for you and the work that you do. So from MHDC, from our constituents, our members, our community, we want to thank you for the work you do. We want to thank you for sharing that with us today. I want to thank our audiences for joining us. We will have the presentation and the video of the presentation online on our website in about 72 hours, 3 working days usually takes us. So please look for that if you're interested in following up. And on behalf of the Massachusetts Health Data Consortium and our colleagues at PointofCare Partners, I want to thank you all for joining us today. And with that, we're adjourned.
Thank you very much, Jenny.
Thank you so much.
Thank you all.
Thanks, Pooja.